In this video, I'm going to discuss the pathophysiology of different brain tumors. So the question that I have for you here is that what is the most common type of brain tumor? And the answer is metastatic tumors. So metastatic tumors account for more than 50% of all the cases of brain tumors. And tissues that commonly metastasize to the brain include skin, or more specifically melanoma, breast, and the lung. Cancer will metastasize to the brain, and these tumors account for more than 50% cases of the brain tumors. Now, one way you can memorize these tissues is that by looking at your chest, the first thing that you see is the skin, and then underneath the skin lies the breast, and then underneath the breast is your lung. So skin, breast, and lungs are the common tissues that will metastasize to the brain. Now, characteristics of metastatic tumors include well circumscribed lesions, and these lesions are usually multiple, versus primary brain tumors, which are listed here, that are not well circumscribed and are usually single. Now, another characteristics of metastatic brain tumors is that they are usually located at the junction between the gray and white brain matter. Now here I have the list of the primary brain tumors. So in adults, glioblastoma is the most common brain tumor, and then after that meningioma, and then finally schwannoma is the third most common primary brain tumor in the adults. In children, astrocytoma is the most common brain tumor, and then after that medulloblastoma, and then ependymoma. And then you should know that astrocytoma is benign while medulloblastoma is malignant. And so if they ask you what is the most common malignant brain tumor in children, the answer would be medulloblastoma, because astrocytoma, despite its being more common than medulloblastoma, is benign. Now, one memory aid that I have for you to memorize the order of these tumors is GM same. So think of GM company is making the same cars. So GM same. So GM same. And so the first three are for the adults, so glioblastoma, meningioma, and schwannoma. And then the next three are for children, which includes the astrocytoma, medulloblastoma, and ependymoma. Okay, now next we can go over the pathophysiology of different brain tumors, starting with glioblastoma multiforme, which is a grade 4 astrocytoma, which is highly malignant. And so since this type of tumor can cross the brain via the corpus callosum and go to the other side, it usually has a butterfly appearance, like this. And then on histology, you will see pseudopalisading necrosis, where there are areas of necrosis that are surrounded by rows of neoplastic cells. So let me show you an example of pseudopalisading necrosis. So here we have an example of pseudopalisading necrosis, where there is an area of necrosis surrounded by rows of the neoplastic cells. And then, just as I told you earlier, this type of tumor is the most common primary brain tumor in the adults. Now, one memory aid that I have for you is to memorize this sentence: blast multiple butterflies. So glioblastoma multiforme has a butterfly appearance. So blast multiple, glioblastoma multiple, has a butterfly appearance. The next tumor is the pilocytic astrocytoma, which is a grade 1 astrocytoma. And then this type of tumor is usually found in the posterior fossa in the cerebellum. And then on the histology, you will see Rosenthal fibers that has eosinophilic structures inside them. So let me show you an example of Rosenthal fibers. So here is an example of Rosenthal fibers, though you will see the eosinophilic structures that are seen on histology of these tumors. And then another feature of the pilocytic astrocytoma is that you would see a cavity in the posterior fossa, so you can see that the lesion is now in the cerebellum. And it contains a cavity with a nodule that is attached to its wall. So a cavity and a nodule that is attached to its wall and is found in the cerebellum is highly suggestive of the pilocytic astrocytoma. and then on histology of these tumors, you will see the Rosenthal fibers. And then given that both glioblastoma multiforme and pilocytic astrocytoma are arising from the astrocytes, therefore for the immunostaining, both of these tumors are positive with the GFAP. So just keep that in mind. Glioblastoma multiforme and astrocytoma are both being stained positive with the GFAP. And then one memory aid that I have for this type of tumor is Rose astrology. So with the pilocytic astrocytoma, you will see the Rosenthal fibers on the histology. The next type of tumor that we have is oligodendroglioma, which has a fried egg appearance with a perinuclear halo. So the memory aid that I have for you is that oligodendroglioma presents with a perinuclear halo. And so here is an example of oligodendroglioma where you would see the nucleus with a perinuclear halo. And once you look from the top, you would see the egg yolk here at the center and then the egg white all around it. So therefore it has a fried egg appearance. The next type of tumor is ependymoma. So the ependymal cells are the ciliated neurons that line the ventricles as well as the central canal of the spinal cord. So therefore, the tumor of these ependymal cells, which is referred to as ependymoma, arise usually from the fourth ventricle, and thus it will cause hydrocephalus. And then on histology, you will see the perivascular rosettes as well as pseudorosettes. So here we have the malignant cells that are all surrounding the lumen, and this is characteristics of the ependymoma. Likewise, medulloblastoma can also present with the pseudorosettes, but then the characteristics of these cells is blue, small with round cells. So here you can see blue, round, small cells that are shown there. And then this type of tumor is highly malignant, and it usually arises from the cerebellar area, and it's a form of the primitive neuroectoderm tumor. So important features of the medulloblastoma is highly malignant, usually arises from the cerebellum, and it's a form of the primitive neuroectoderm tumor. On histology, you will see blue small round cells with pseudorosettes. And so since this type of tumor can also compress the fourth ventricle, therefore hydrocephalus is another characteristic of the medulloblastoma. So let me show you that the most common tumors in the children were medulloblastoma and ependymoma, both of which can now block the fourth ventricle, as a consequence of which they could cause hydrocephalus. And then another feature of the childhood tumors is that astrocytoma and medulloblastoma are arising from the posterior fossa or the cerebellum. Next, we have the meningioma, which arises from arachnoid cells, and it attaches to the dura, and so since it will cause compression of the brain, it can cause seizures. Now, on histology, characteristics of meningioma include the psammoma bodies, which are shown right here, which are the calcification structures that are seen with the meningioma, and there are also whorled patterns that are seen due to the concentrating structures of the spindle cells. Now, this type of tumor expresses estrogen receptors and is more commonly found in females. Next, we have the schwannoma, which usually arises from the cerebellopontine angle, and thus it will affect the cranial nerve 8, as a consequence of which it will cause hearing loss as well as the tinnitus. Now, this type of tumor is associated with the Neurofibromatosis type 2, and thus it will cause bilateral acoustic neuroma in this disorder. And then the tumor marker that is used for schwannoma is the S100. So the memory aid that I have for you is that schwannoma can be detected, so schwannoma can be detected by S100. The next and final brain tumor is the craniopharyngioma, which derives from the Rathke's pouch, which is an ectodermal outpouching at around 3 to 4 weeks of gestation that gives rise to the primitive oral cavity. And then on histology of these tumors, you will see the adamantinoma, which is a tumor of the tooth. So this type of tumor, one important characteristic is that it's calcified and it compresses the optic chiasm, as a consequence of which it will cause bitemporal hemianopia. So on the vision field, the patient cannot see the temporal size of the eye. And then the question that I have for you here is that what other type of tumor is associated with the bitemporal hemianopia? And the answer is pituitary adenoma, which also causes compression of the optic chiasm, as a consequence of which it will cause bitemporal hemianopia. Now, another question that I would like to ask you is that what is the most common pituitary adenoma? And the answer is prolactinoma is the most common pituitary adenoma. So let me explain how the compression of the optic chiasm will give rise to the bitemporal hemianopia. So here on the black line structure that I've shown you here is where the optic chiasm is located. So by compressing the optic chiasm, what happens is that the nasal part of the retina will be destroyed. So this part as well as this part will be destroyed. And this part of the retina is responsible for the temporal vision. So the lateral side, this side and that side, are being responsible to be seen by these parts of the retina, and thus these patients will present with the bitemporal hemianopia because of the compression of the optic chiasm. And that concludes our discussion of the metastatic as well as the primary brain tumors.